Good morning, everyone, and welcome to Health First Colorado's SUD benefit expansion pre-implementation provider training, presented to you by Health First Colorado, otherwise known as the Department of Healthcare Policy and Financing, otherwise known as Colorado Medicaid. My name is Victoria Lasky. I'm the SUD Treatment Access Specialist, and I am joined here today by Dr. Kim McConnell, the ACC SUD Administrator. Shingo is not with us this morning, but he did help get all of you registered and get you the webinar link, so I decided to keep him on the side to give him some credit there. I would like to start out by giving a big shout out and thanks to Kelly O'Brien at the department, who is doing all of our tech behind the scenes magic, and also thank all of our presenters who are joining us today. And we will go ahead and get started. So we like to take a moment to just pause and read over the department's mission. So I'll give you about 10 seconds to read our mission. As you can see on this slide and also in the agenda, we have a lot of different topics teed up today to go over. So that includes the SUD benefit expansion, Medicaid enrollment for providers, billing procedures, the ACAM criteria and medical necessity, utilization management, provider requirements and licensure, and then we also have presentations coming from the RAISE and MSOs today. So if you do have a question, we would like you to use the Q&A function to submit it. We're going to have a couple hundreds of you joining us today, so we have muted all your lines, and there's no way for you to unmute. So if your dog starts barking or you want to eat a particularly crunchy snack, no worries, go ahead, we will not hear you. If you would like to submit a question, there is a Q&A box that we would like you to use. After most presentations, there will be an opportunity to ask questions. So you will submit your question in the box, it will come to the presenters, and then we will be able to answer them. So we are limited by time today. We may not have a chance to get to all of the questions. If there are any questions that are not addressed that you would like to pose to us, you can write those down and go ahead and email them to Shingo and myself. We currently have an FAQ that's available for download. I'm going to mention more about that in a minute, but we are thinking about maybe doing an FAQ 2.0, so it's great to be able to get all of your questions and hopefully be able to address them. And again, questions are welcome. So we are very knowledgeable presenters, and we are also not the subject matter experts on everything. This is my cat's tail right here. I'm going to remove him. We may not be the subject matter experts on everything. So if anything comes up that we are not able to answer in the moment today, we can take that back to our teams and get those answers and then hopefully get those out to you in an FAQ 2.0 or another way to make sure that your questions are getting answered. A few housekeeping items. So as I mentioned, everyone will be muted during the duration of the training. Today's training is being recorded. We are planning to upload the videos of this training to our website so that you may reference it later, or if you want to send it to all your friends, you can do that. If you have to step out for part of the training today, you should be able to reference the full training recording later. We do have a tight agenda with some short breaks. Last time we did run a little ahead of schedule, so if there is a situation where we are running a little ahead of schedule, I'll give you a warning now that the breaks may be extended just a little bit. We do have presenters coming on at certain times, so we are unable to completely expedite everything. What we would do is just extend the break if necessary. We may not have time to do that today. You will notice a little box that says downloadable files. That is your goodie bag for attending the training today. So what you will find there is our agenda. You will find the presentation slides. You will find contact information for the RAISE and MSOs, and the first version of our FAQ, which is also found on our webpage. After the training, you will be immediately directed to a survey to provide us some feedback. So we would love to hear what went well today, what we could do better, so that we can take that into consideration as we continue to develop training and provider education opportunities at the department. Kim, do you have any additional housekeeping items or anything else?
Thanks for getting us started, Victoria.
Great. All right. I'll go ahead and pass it over to you. Take it away.
Okay, super. Thanks. I did want to just extend thanks to everybody that's participating today. There are a lot of folks that everyone on this call has put time and effort into thinking through how to participate in the new benefit, and many people have been instrumental in organizing and planning for it. And we appreciate, your patience as a provider in awaiting information that you'll need to get started in January. And we also really appreciate the work that you've put into thinking through how to participate in Medicaid's payment of residential and inpatient services. It's a big lift for everyone. And I'm just very thankful for all the effort and thought that's gone into it thus far and the work that we'll be doing together from this point. So to give you a little bit of background about the benefit and what's coming, we'll start with just acknowledging or discussing the bill that passed in 2018. So House Bill 1136 compelled our department, so the Department of Healthcare Policy and Financing, to identify the federal authorities that would be required to open coverage of residential and inpatient SUD services. So in order to cover these services, we need both state authority and federal authority to cover under Medicaid. And state authority was granted through 1136 to use, part, general state funds in order to fund the services. But for the federal portion of the Medicaid payments, we need three authorities in place. The first one is that we need to add these services to the state plan. So anything that's covered under any authority has to be reflected in the state plan. We're in the process of, we've submitted a state plan amendment to include the new services. In addition to that, in order to cover the services in any facility, including a larger facility, so a facility of 16 beds or more that is primarily offering behavioral health services, is called an institution for mental disease, an IMD, according to CMS, the federal arm of Medicaid, the Centers for Medicare and Medicaid Services. And in order to be able to cover the services in those larger facilities, we had to submit an 1115 demonstration application. And that was done in October 2019, and we are very close, according to the communications that we've had recently with our federal partners, of having approval for that demonstration, which is very exciting. There's one more federal authority, and that's a 1915B waiver, and that just allows us to incorporate these services into our current delivery system, which I'll talk about as we get a little further along today. Okay, so that was really the first step. In order to be able to pay for these services with both federal and state dollars, we have to get those approvals and those authorities. Okay, so what is it that's changing, and what is it that Medicaid currently covers and will cover in the future? So the American Society of Addiction Medicine defines a continuum of care for substance use disorder treatment services, and you can see it here in your slides. You can see over on the left the services that are provided on an outpatient basis, and as you go further over to the right, they're more intense services, and that goes all the way to medically managed inpatient services that are typically offered in a general hospital. So over on the left, you can see 0.5 or early intervention. So those are services like screening, brief intervention, referral to treatment, and those happen in a variety of different settings. Some of the settings that you might see those services offered in would be a primary care office. It could be an emergency department. It could be, a specialty physician's office if there's screening being done, or if there's a substance use behavior that's identified as problematic as it interacts with a medical condition. It might be that someone is being seen for mental health services and some screening is done, or there's a substance use problem that's identified in that setting. And so early intervention is something that's currently covered by Colorado Medicaid. As you go a little bit to the right, you can see outpatient services, and probably everyone here is really familiar with what those are. It's our traditional service delivery. Oftentimes it's group or individual therapy. It includes assessments for substance use disorders. It could be a psychological evaluation that examines the substance use. So a variety of outpatient services. Going further to the right, We have the level 2 services, and those are intensive outpatient, which is defined by ASAM as services that are more intensive in nature, and they occur at least 9 hours per week is one of the distinctions between outpatient and intensive outpatient. Of course, this is for folks that have not been able to manage the behavior change related to their substance use with the lower level of services, or it's believed that when they're assessed that that's the most appropriate level of care for the needs that they have. Further to the right of that, you can see 2.5 is partial hospitalization. That's also maybe more commonly known as day treatment services. You go further to the right, then you get into the residential and inpatient categories of care. So you can see 3.1 clinically managed low intensity residential services. So that's the lowest level of residential services. And we have a presenter from the Office of Behavioral Health to talk about their licensure changes that recently were ratified and actually align the SUD provider licensure rules in Colorado more closely with this continuum that you see here. So now the licensure rules reflect licenses by level of care. So these 3.1 services, are residential services. So by definition, the individual's living in an environment. That is one of the essential pieces, and it's if you read through the ASAM criteria and see whose needs are matched to 3.1 services, it's for folks that haven't been able to make change or maintain their recovery changes in an outpatient environment. So they need a more structured environment in order to make progress or to maintain changes over a longer period of time. 3.3 services are interesting-ish, or let's say they're categorically different than 3.1 or 3.3 that bookend the 3.5 and 3.1 that bookend the 3.3 level. They are not sort of a halfway point between 3.1 and 3.5 in terms of the intensity of services that are provided. They're actually designed for a specific population of folks that have cognitive impairments that prevent them from being able to successfully participate in 3.1 or 3.5 services. So it could be someone that has a traumatic brain injury. It could be someone that has cognitive dysfunction related to long-term alcohol use. It could be a temporary or a more permanent cognitive impairment. But the reason that 3.3 exists is because those folks are not able to benefit from the learning that they might be needing to do at 3.1 in the way that the group sessions or the treatment program or curriculum is delivered traditionally in 3.1 or 3.5. So they need extra supports to be able to utilize the treatment that's being provided, or their cognitive impairment makes it difficult for them to participate in the residential environment, and they need more supports for managing their behaviors in a social environment. 3.3 is really categorically different for a different population. 3.5 is clinically managed high-intensity residential services. So you'll see more supports for could be psychiatric or medical conditions. Also, you'll see more treatment, more intensive treatment services being delivered. Sometimes it'll be a different curricula that's offered, say, in 3.1 programs, or just more treatment contact hours with a variety of interventions, including psychoeducation, family, and so on and so forth. Most of you, this is old hat, and you know this well, but I wanted to just be real clear at the outset. So which services we're talking about being added. 3.7 is distinguished from the lower levels of residential care by ASAM as one that offers more supports specifically and especially in the medical realm. So the access to medical professionals and the length or the amount of time in a 24-hour period that medical professionals are available and medical assessments are done. Those services are more available at 3.7. Same thing is true of psychiatric care at 3.7. So an individual that has co-occurring mental health or medical problems may need 3.7 level of care. Level 4 services are even higher in terms of the access to medical care that's offered. Most of the time, those services will be delivered in general hospital settings. So we've got the continuum of treatment services. I haven't talked about withdrawal management yet, but let's look at the continuum of care that's available through Health First Colorado. So you can see along that first continuum at the top of the slide, you can see the treatment services, and those that are shown in blue are the ones that are currently covered by Health First Colorado. So we cover the outpatient services up to residential, where you see it's green. We don't currently cover that. Right now, those services are funded for Medicaid members and uninsured or underinsured individuals in Colorado through the Office of Behavioral Health's block grant, and that money, the SAMHSA block grant dollars flow through the Office of Behavioral Health, and they are managed, those services are managed through OBH's MSOs, or managed service organizations, who you'll hear from later on today. You can see the inpatient level of care is 3, 7, and 4 as defined by ASAM. We don't currently reimburse for level 3.7 services. That's one of the things that's being added. And then finally, the level 4 services are currently covered through physical health benefit, and that won't change. So that will continue just as it is. Lauren, I see a question from you. What is Health First Colorado? It's Colorado's Medicaid program. Yep, that is what we call it. All right. Down on the bottom row, you can see withdrawal management services. So you can see the full ASAM continuum there. Right now, ambulatory withdrawal management is not included in the behavioral health benefits. However, it is billable through physicians through the physical health benefit. So it is a billable service as an office visit, and certainly through the pharmacy benefit, any medications are covered as well. If you move a little bit to the middle, actually, you can see clinically managed withdrawal management. That's 3.2 withdrawal management. We commonly call that, or refer to it currently in the state plan, as social detox. So it is, it's a level of care where the individual is in a facility being monitored for signs and symptoms of withdrawal. And we currently do cover that. We'll talk about a change that's coming in the way that that's reimbursed. As you move a little bit further to the right, you can see medically monitored withdrawal management. We don't currently cover that, but that's being added with this new residential and inpatient service benefit. Okay. Now there's a question from Rochelle, and I'll answer most questions in our Q&A, but thanks for sending these in, and it's easy for me to tag this in now. Does this include services for adolescents? So yes, once these services go into the state plan, it applies to the entire eligible Medicaid population, and that includes adolescents as well. So services in non-IMDs are covered for adolescents, and then they are covered in IMDs under EPSDT. Okay, so I mentioned a change that's coming to social detox. So here it is. Right now, billing for social detox is done through these 4 individual codes that are billed X number of times on a 24-hour basis. It's changing to a per diem rate, and that's the code that'll be billed. Not so much interested in the codes right now, but just thinking structurally about how the reimbursement process is changing. This is it. We'll get into greater detail later this morning as we go through the coding pages and orient you to the billing process. But this is just a little bit of a preview and helping you understand how structurally that reimbursement will change. Okay, so the delivery system for services. Almost all the claims that will be submitted will go through the RAISE. This benefit is going to be managed just as the rest of our behavioral health services are through the RAISE. What are the RAISE? RAISE are the regional accountable entities that the department contracts with to manage the physical and behavioral health services that are delivered to the members in their regions. So the RAISE, we'll talk a little bit more about this, but the state's divided into 7 regions, and the RAISE manage those services, physical and behavioral health, for all the members assigned to their RAI. The vast majority of services will be billed through the RAISE. There is only, the only exception will be those instances where a member is a new Health First Colorado member and has not yet enrolled with a RAI. Then those services would be billed fee-for-service, but that'll occur in very rare instances. So providers will need to be billing through the RAYs, and we'll talk about how what steps need to occur in order to get there. Okay. So I mentioned the behavioral health program. Well, the behavioral health services are managed through a behavioral health capitation. So a predetermined amount of money is paid to the RAYs, and the RAYs manage the services from that capitation payment. These services are being built, the SUD residential and inpatient services are being built into the capitation payments that the RAYs receive. As with all the services that are billed under the capitation, there will be no copays, no cost sharing for members. The RAYs will be doing a number of things to manage the benefit. One of the things that they'll be doing is developing networks, and they'll have networks available at every SUD care level. So they currently have networks for outpatient and intensive outpatient, and they are in the process of developing networks for 3-1, 3-3, 3-5, 3-7, and the 2 withdrawal management levels of care as well. They'll also be doing utilization management, so they'll be doing some prior authorization that we'll talk about in depth as we get further along this morning for services. They will also be providing and managing care coordination for those services as well. Victoria, I'll let you take this special connections.
Thank you. So in addition to being the SUD treatment access specialist, I also oversee the Special Connections program, which, if you haven't heard of it before, it is our treatment program for pregnant and parenting individuals with substance use disorder. It is currently the only benefit in Colorado that is a residential SUD benefit. So previously, this has been billed fee-for-service directly to Health First Colorado. How that will be changing in the future is that it will be transitioning to being managed by the RAYs along with the other services in the continuum. So what that means is Special Connections programs will need to contract with, it says at least one RAY, but really they will need to contract with any RAY that they intend to bill for services to continue to participate as a Special Connections provider. Programs will continue to be certified by the Office of Behavioral Health for gender responsive treatment, so that's what distinguishes a Special Connections provider is that specific designation for gender responsive treatment. That will not change. Your OBH license that designates gender responsive treatment will be uploaded to the department to confirm your enrollment as a Special Connections provider. Just as a note, per some recent legislation, House Bill 1911-93, eligibility to enroll in Special Connections has been extended. So previously, women could only enroll in Special Connections while they were pregnant. They could continue to receive services up to 1 year postpartum, but they were unable to enroll postpartum. That will be changing. Women will be able to enroll postpartum per this legislation. Back to you.
Thanks, Victoria. Okay, so a little bit more about the benefit and the policies that will apply. All Medicaid services require medical necessity. So the services are not reimbursable unless medical necessity for the services are established. For the residential and inpatient services, a couple things are required. One, medical necessity is required for the services. So how will medical necessity be determined? What's the criteria for that? We will, as a state, we will be using the ASAM criteria to demonstrate medical necessity. I'm going to go into detail on, how the ASAM criteria is used, but in a nutshell, just to sort of set the stage, the ASAM criteria matches an individual's needs to a particular level of care. And when it's demonstrated by a provider to a RAY that the individual's needs are appropriate for a particular level of care, then medical necessity is met. So if according to the use of the ASAM criteria, an individual's needs match a level of care, the level of care being recommended, then medical necessity has been established for these services. So that criteria for medical necessity is going to be universal and applied across all RAYs. That's the criteria each of them will be using. In addition to medical necessity, the member needs to have a current SUD primary diagnosis in order for the services to be reimbursable. I mentioned before that the RAIs will conduct utilization management, and for treatment services, they will require prior authorization for those services. We'll talk about this in detail later. Prior authorization is not going to be required for withdrawal management because of the oftentimes urgent nature to get those services, to get individuals into withdrawal management or detox programs. We didn't want there to be a process barrier. However, providers are responsible for ensuring that the people that they are treating have medical necessity for those services. So the RAIs will be doing look-backs to ensure that when care was rendered, that it was medically necessary. All right. Okay, so can IMDs, or institutions for mental disease, bill for these services? Yes, they can. Because of the 1115 waiver authority that we will have, we will be able to use Medicaid funds for SUD treatment in IMDs. Nothing is changing on the policies surrounding psychiatric stays in institutions for mental disease. That is remaining the same. That's remaining untouched at this time. But the 1115 waiver allows us to cover services in facilities of 16 beds or more that are primarily engaged in providing behavioral health care services. We can now reimburse for services in those facilities. Okay. So I'm going to pause there, and we'll take a little time for question and answer. Now, let me take a minute to just see what we have. Victoria, there is a question that pertains to special connections. Do they still need to be within the first year of postpartum to enroll?
Thanks for that question, Michelle. So in order to enroll and participate in the Special Connections specific programming, yes, it would be within that 1 year of postpartum. However, if mom is past that 1 year of postpartum, she would then be eligible to receive services from the larger SUD benefit. So that answers your question.
Okay, great. Hopefully that clears that up. There's a question about primary diagnoses. For these services to be reimbursed, SUD needs to be the primary diagnosis. All right, another question about pre-approvals. So all residential clients will need to be pre-approved by the RAI, is the question. Also, if ASAM indicated 3.1 and the client is at 3.5 or 3.7, will that disqualify the approval? All treatment services will require prior authorization. So the RAI will, the provider will submit the PAR, the prior authorization form, and the RAI will review it and then communicate a decision as to whether it's approved or denied. We'll go into that in greater detail momentarily. That's true for treatment services, but not withdrawal management. Let's see, the second part of that question, if ASAM indicated 3.1 and the client is at 3.5 or 3.7, will that disqualify the approval? So the individual, these are prior authorizations, so the person needs to be approved for reimbursement prior to the initiation of treatment. If it is determined that there is not a bed available at a particular level of care, then the RAI will work with the provider and look at the member's case to determine what the most appropriate placement is based on clinical need. We're looking for the best match in treatment, and we understand that sometimes the exact level of care won't be available, and so those decisions will be made on a case-by-case basis as to what's clinically appropriate for that person given the availability of treatment services at various levels of care in the system. So those decisions are made on a case-by-case basis. There's a question about, will the RAE be responsible for entire claims if there are medical issues with an SUD diagnosis? So if there are medical issues, then likely the individual will need a higher level of care. So perhaps they go into 3.7, and then those services are generally included. If the person is most appropriate for their SUD treatment at 3.1 and they need outpatient physical health services, or they break their leg, or sprain their ankle and need an x-ray and an orthopedic visit during the time that they're there, then those are billed separately under the physical health benefit while the individual is in treatment. Will we know what the criteria looks like for medical necessity? It is ASAM criteria. So we'll go into that in greater detail, but yes, it is the ASAM criteria. Can a 3.5 facility request approval for a 3.1 client? I'm still not clear on that question. Can a 3.5, so when we say a 3.1 client, are we talking about someone that's been assessed to need 3.1 services? And can they get approved for services at 3.5? Well, it would depend on what's available. The RAE would be looking to place that individual in a 3.1 facility if what their needs are is 3.1 level of care. There's a question. Uh-oh, I lost that question. I'm losing questions quickly. So I'm looking for Art Scott's question, if we can restore that one. Our questions are going away a little too fast for me to get to them. 3.7 level of care is listed as an inpatient level of care. But other level 3 ASAM services are residential. Yep, that is accurate. Is there a difference between inpatient and residential levels noted? The difference is really there. What distinguishes 3.5 from 3.7 is the availability, frequency of availability, and level of expertise offered in sort of the medical realm. And the psychiatric realm. That's what distinguishes a 3.5 and 3.7 level of care. We'll talk a little bit about different provider types that you would see offering services at the 3.5 versus 3.7 level. And I'll get into that in a little bit more detail later. Okay, another question. If I have a license on one unit for 3.5 and a 3.7, I assume that means a license for 3.7 on that same unit, and the client meets 3.7, let's say, let me see if I can state that differently. I assume that the individual means that the individual has medical necessity for level 3.7. Can we step them down to 3.5 without authorization? You would want to communicate with the RAE about a change in level of care and then work with them according to their policy around those shifts. Okay. We're located in a rural community with residential treatment services being 3 to 4 hours away, and that's going to be true for many of our members. Will the RAE cover the cost of transportation to inpatient residential treatment? So we, as in Health First Colorado, has a non-emergency medical transportation benefit, and that can be used to transport an individual to any service that Medicaid is reimbursing for, and that includes residential and inpatient care. So if a person lives in Routt County and is going to the Front Range for residential treatment, it could be arranged for that individual transported to that facility for their residential stay. Okay. What recourse will providers have if they disagree with the RAE? So it's the same policy for management of denials, and I'll let the RAEs touch on that. That's a good question. But there's a question, let me just restate it or say it again. What happens if a provider or a member specifically disagrees with the decision that a RAE made about whether or not about a prior authorization request, basically, or about the level of care that's needed for an individual. So it's the same procedure that that a member and that a provider may engage in conversation with a RAE. But the RAEs will talk about the way that prior authorizations will be handled a little bit later in the presentation. Okay, here's our question again. Let's see. ASAM criteria definition of medical necessity includes what is often referred to as clinical necessity. I assume the use of medical necessity is true to the ASAM definition. That is correct, yes. Yep. So if the individual's needs, when the individual's needs match to a level of care, then medical necessity for that particular level of care has been established. When will future coverage take effect? Thanks, Letitia. I should have started with that. The benefit, as we are calling it, goes live on January 1st, 2021. These services are reimbursable through Colorado's Medicaid program beginning January 2021. Do you have in writing the documentation requirements for 3.7? So we will be showing you the coding pages momentarily. We're also going to be talking about a provider manual that we anticipate being able to publish or put on our website and make widely available in the next week. And so we will be sharing all of the requirements for providers and the billing rules and procedures for every level of care. And I think that's what this question is getting at. So that will be available in writing through the provider manual and the coding pages very soon. What is the average length of stay for 3.7? Well, that's a great question. And it's one that's not entirely clear. I can't tell you what the Medicaid data says because we don't have any Medicaid data on this. We don't currently pay for that level of care. So I can't speak for the Office of Behavioral Health. They're currently paying for those services. But what becomes really tricky is that the licensure rules have changed about level 3.5 and 3.7. So even if we were to take a look back at data that's been collected over, say, the past 2 or 3 years, or even just the last year, it may look quite different in the coming year as programs relicense based on the new licensure rules. Tom's going to talk, Tom Miller from the Office of Behavioral Health will talk about how the licensure rules have changed. The requirement for access to a medical provider is one of the shifts that occurred in the requirements for 3.7. So some programs that are currently licensed as 3.7 may change their licensure to a 3.5 because they are more closely matched with those licensure rules and want to maintain services that are consistent with that level of care rather than the new rules surrounding 3.7. So because of these multiple factors, I don't have an average length of stay at 3.7. We will have that information pretty shortly as we open up the benefit, but right now that is a bit of a shifting piece of data. Can we start working with a RAE prior to January 1st so that the client can start receiving some of these services as soon as they go live? So many programs are already contracted and credentialed with the RAEs because they offer outpatient services or IOP services. We'll talk about the contracting and credentialing and all the steps that are needed to be ready to bill for services in January. So absolutely you can start working with a RAE unless you're billing for outpatient or intensive outpatient services. You can't start billing the RAE for residential services until January 1. But I hope to provide a lot of information that will provide greater clarity on that issue and that question as we go through the training this morning. There's a request. Oh, yeah, the slides will be available. They're available now in the downloadable files section of this Adobe Connect interface. Okay, will the MSOs pay for patient days when the RAEs assert that the patients no longer meet medical necessity? So I'm going to let the MSOs speak for themselves on this. My understanding is that services billed through the MSO should also have medical necessity, but we certainly aren't setting rules for any services, treatment services paid by the MSO. So that question I'll leave to the MSOs later in the presentation. Any other questions? One of the things I will say.
All the time we have right now.
Okay, all right. Okay, we'll probably get to that later. Yeah. Okay, thanks, Victoria, for moving us along, keeping us on schedule. All right, what do we have next? Oh yeah, I forgot. It's me. I'm supposed to advance these slides. Okay. All right. ASAM medical necessity. So what are we talking about? I've been referencing this, and we're going to go into greater detail now. Okay. So the ASAM process, what does that look like? Oh, we're probably familiar with this. A little recap, and what I really want to do is link it to the benefit and talk about how ASAM links to the benefit and how it's going to be applied. So when provider uses the ASAM criteria to make decisions about patient placement and an individual's needs, the first thing they do is conduct a biopsychosocial assessment. So they're going to collect information from the individual and their records and other providers and all of the ways that maybe collateral, whatever it is that a clinician the data gathering process that they may use to understand the client's needs. They're going to do the biopsych assessment. Is there an ASAM assessment? Well, no, not an ASAM itself is not an assessment. The ASAM criteria is applied to the assessment data to make decisions about level of care. So ASAM itself is not the ASAM criteria is not an assessment. Now, so what assessments could you or should you use in order to gather this information? Well, a good place to start would be the ASI. You would also need to do, in addition to the ASI, not the American Society of Addiction Medicine, but the Addiction Severity Index, you'd also need to collect some information about withdrawal symptoms and signs. So those two things can give you all of the information that you need to apply the ASAM criteria. If your program is using the GAIN already, that's an appropriate assessment tool as well that will help you make decisions about treatment needs as well. Your program may have a comprehensive biopsychosocial assessment that covers all of the things that are covered in the ASI. Or all of the information that is needed to apply the ASAM criteria, and that's fine right now too. So you need to conduct an assessment. The next thing you do, and this is all contained in the ASAM criteria book, the next thing a clinician does is assign risk ratings to the 6 dimensions. I'll go over those 6 dimensions in just a moment. The next step then is to take those 6 dimensions and crosswalk those risk ratings to a particular level of care, and there's a matrix in the ASAM criteria that tells clinicians that if the risk rating is X on this dimension, then you need to consider this level of care. So there's a stepwise process going through the 6 dimensions that allows you to, as a clinician, to determine which level of care is appropriate for the person that is before you. So the biopsychosocial assessment, what are the things that are what kinds of data, what are the areas of data that are collected on the client. You can see here history of the present episode of substance use, family history of substance use and substance use problems, developmental history, their drug and alcohol use, tobacco use as well, legal history, psychiatric history, medical history, spiritual history, review of systems, the mental status exam, physical examination, formulation of diagnoses, survey of assets, vulnerabilities, and supports, so the things that may mitigate the problems, and treatment recommendations. Okay, so providers should use an assessment tool that's validated to gather that information. Those 6 dimensions that I mentioned before here. So we've got the intoxication or withdrawal potential. Do you have someone that has need for withdrawal management before you can even talk about treatment with them or before they can participate in treatment? Do they have biomedical conditions and complications? So they have a medical problem that is going to impact their ability to participate in treatment, or something that needs to be attended to as a primary concern as they engage in treatment. Will they need, special monitoring? Will they need, to work with a nurse on a daily basis to monitor some medical condition, while they are in treatment? What are their, dimension 3, their emotional, behavioral, or cognitive conditions that impact the recovery efforts that they will be engaged in, or when they're in SUD treatment? What's their readiness to change? So ASAM does take into account an individual's readiness to change when looking at levels of care. Relapse, continued use, or problem potential also will drive whether or not if they've been successful in outpatient treatment before, or whether or not their environment is so risky, presents so many opportunities for relapse and struggle with regard to changing their behavior that perhaps they need a residential level of care, or perhaps they have so many supports in their environment that actually outpatient or IOP treatment is preferable to residential. And then finally, recovery living environment. Okay, so the risk ratings are assigned to each of those dimensions, and then the level of care decision making happens next. We encourage clients, not clients, but clinicians. We offer, or the MSOs helped us offer training, let's see, was it July, maybe summertime, on the ASAM criteria, and providers should be working to ensure that all of their clinicians and staff are trained on the ASAM criteria in order to be able to utilize it and apply it. Okay, so who can use the ASAM criteria? ASAM says that credentialed counselors, clinicians, certified addiction registered nurses, and psychologists and physicians can use the ASAM criteria for this level of care decision making. The interpretation, of course, as always, should be within the scope of their practice. Okay, we're going to continue on, and we're going to talk about utilization management because it's linked to what I just covered on ASAM, and then we'll have our question and answer session for this topic. Okay, so prior authorization request, PARs. Okay, so in what situations would a prior authorization be required? So prior authorizations will be required for any of the treatment services. So 3.1, 3.3, or 3.5 will require a prior authorization. So the clinician will conduct the assessment, and they will determine the level of care that's needed, and then they will document it on the RAI's prior authorization form. RAI will review it and then issue a decision. Admission to the withdrawal management services, 3.2 and 3.7 are not required. We didn't want an operational step in there that would prevent people from beginning treatment. However, it is the provider's responsibility to ensure that the people that they are admitting and initiating treatment with have medical necessity for the services that are being rendered. The RAI will do utilization management. They'll do a look back at medical necessity for the individuals in the members in their region. Is a PAR required for those rare instances where a member is not yet enrolled with a RAI? There is no prior authorization process for the claims that are going to go fee for service for those not yet enrolled with a RAI. Again, this is going to be a very, very tiny fraction of patients, but there is not a prior authorization process for that when claims are submitted directly to Health First Colorado to the interchange system. Billing and coding, we'll talk about that later. It's exactly the same for the fee-for-service claims as it is for the services going through the RAIs. Okay, so what is the time frame for prior authorization? The time frame from submission of the prior authorization by the provider to a decision from the RAI is 72 hours, and that's calendar hours regardless of the day of the week. So the RAI will respond to the prior authorization request within 72 hours. That is the latest that they can respond. In many instances, they'll respond sooner than that, but that's the latest that they could respond. For special connections programs, those prior authorizations will be reviewed and responded to within 24 hours. how long is a prior authorization valid? So when would a reauthorization be due? There isn't a standard set time for the length of time between prior authorization approval and reauthorization. This will be determined on a case-by-case basis, and it should be determined based on the expectations for progress in treatment for a particular case. It also will vary by the level of risk associated with the individual that's in treatment, and also the level of care that they're in. So higher levels of care will likely require more frequent prior authorizations, and it may vary by ray. The rays can speak to this further when you hear from them later on this morning. Okay, so what's the criteria that will be applied to determine whether or not prior authorizations are approved? So the criteria for medical necessity is the ASAM criteria. So when the RAE looks at the information that's submitted on the client's needs and the decision making that's documented by the provider as to which level of care is necessary, the RAE is also going to apply their the ASAM criteria from their perspective, and they're going to look at and confirm that, yes, indeed, medical necessity is demonstrated according to the ASAM criteria. This person's needs match the level of care that is being requested, therefore the prior authorization is approved. If there is a mismatch in the level of care that is being requested and the individual's needs, then that claim will likely be denied. What form should my program use to submit a prior authorization? The forms will vary by RAE. We worked with the RAEs early on, probably, gosh, I don't know, 9 months, a year ago, to discuss, what their prior authorization process would look like, what information will be collected. While the form itself will vary by RAE, the information contained is just going to reflect the ASAM criteria, and portal to portal or form to form, you're going to see pretty much identical content. You'll see the ASAM criteria reflected in those prior authorization forms. What happens if a prior authorization is denied? So if a member receives a denial for prior authorization of services, the member has the right to appeal the decision. The process, the policies around those appeals are documented in and described on the RAE's websites and in their policies. And if you have questions about that process, the RAEs can speak to those later this morning as well. Okay, so we will pause there, and I can answer questions about the content that I presented on the ASAM criteria and its application to the benefit and the utilization management process, things we've talked about thus far. Here's a question. We're approved to bill for outpatient and detox services. We have done residential treatment for 44 years. Will we need additional approval from the RAE? It's a little unclear as to what the question, what the person asking the question is specifically questioning. So do you need approval in the sense that do you need to be credentialed by the RAE? Yes, we'll talk about that in a little bit. Do you need prior approvals for these services? Yes. Yeah, prior authorizations are required for each treatment admission for 3-1, 3-3, 3-5, 3-7 services. Is there a contingency in a case where the RAE may not have made an approval to bill residential? We have been told we need a second NPI number, and I'm having trouble getting the second NPI. That is a very specific question. I think I can certainly interact by email and answer. And the RAEs may be able to speak to that as well. I think this is, okay, I think this question pertains to credentialing and becoming a contracted provider by a RAE and an enrolled provider with Health First Colorado. So I think we'll get to the content that'll answer that question better as we go forward. So I'll hold that there. I encourage it to submit more questions as we get a little bit further on in the process of talking about credentialing and licensing and contracting with the RAEs. We'll also talk about Health First Colorado enrollment as well. Okay, here's a question about the application of the ASAM criteria. So ASAM determines the level of care. So the ASAM criteria, the 400-page book, does allow a clinician to take the assessment data and match it to a level of care 3-1, 3-3, 3-5, 3-7. So an individual level of care, not just residential or inpatient or outpatient. There's a question, is there an electronic ASAM program that determines, you know, those individual 3-1, 3-3, 3-5 level of care? So yes and yes. There's also a question, or is that where we use the crossword? You can use the book now, and you can, you know, what you should be doing as of January 1 is using the criteria and the matrix and those risk ratings to figure out where, at what level of care the individual's needs are matched to. In the future, there is a software tool called Continuum that is issued and managed by the American Society of Addiction Medicine, or ASAM, and their technical partner company called FEI. The state has obtained funding to make this software available statewide to providers that are billing Medicaid for residential and inpatient services. This software, we will be footing the cost of the licenses for the software. This is going to, the implementation of that software statewide requires a few things. One is, you know, making the software platform available, which we are working with FEI right now to work towards that. The other thing is that we're going to have to provide fairly extensive training on that software as well. So, but we are in the process of building the contract and the work plans for that. So in the future, you will actually have the Continuum software available to you. Continuum does a few things. It's an excellent product in the sense that the clinician sits down in front of their computer, they log on to Continuum, and they get prompted a series of questions that help them collect all of the data that they need on that client to determine what their needs are. And it's a you know, it's a program that, depending on how you answer one question, it will take you to the next question. You know, if yes, then it takes you to number 7 and asks you ask a few more questions about, say, withdrawal symptoms. If they're having 0 withdrawal symptoms, it skips the rest of the questions. You don't have to waste your time there, and then you go on to the next section. It also 100% automates the risk ratings and the level of care determination process. So it will say, okay, you've got this individual that you answered all these questions on. It will give you the risk ratings, and it will say what's recommended is, say, 3-5 level of care. If 3-5 is not available, you know, for this individual, then other levels of care that could be considered are, say, 3-1 with extra supports, or you know, 3-7 in some cases. So it will give you the recommended level of care, the level of care that is most appropriate for that person, and there may be some information available also in the event that that level of care is not recommended, and then that becomes a conversation between the RAE and the provider. That information, using the use of Continuum, should streamline the UM process even further in the future. So it will automate the use of ASAM. We're actually we're starting to plan some stakeholder work around the implementation of Continuum. So we'll be holding some sessions with providers to really dig into how we can implement the use of Continuum into your current systems, and what are the things that we need to think about, and you know, how do we phase this in? And so we'll spend a lot of time working on that and having conversations with you all in advance of making that a requirement, and in advance of that software going live and doing the training. So that is to come, and we invite you to stay tuned for that conversation with our department. Okay. Yeah, so the question, are RAE responses within 72 hours inclusive weekends and holidays? Yep. So if you submit it on Friday, 72 hours later, regardless of whether Saturday and Sunday are happening, you will have your final answer. In our case, many clients come from many miles away for residential treatment. That is often true. What is allowed for us to do a remote ASAM if it will make little sense to have the potential client travel 90 to 150 miles to get the ASAM and then have to wait up to 72 hours to know if it's accepted and admitted. So this is something that should be handled through the RAISE, the exploration of whether telehealth services could be used to conduct the assessment. So we're traditionally a 30-day residential treatment program. Did I understand correctly that we will need to get multiple approvals during that 30-day period? It depends. So length of stay should be determined by medical necessity. So an individual, the services are reimbursable as long as an individual continues to have medical necessity for the level of care that they are in. Like I said early on, the RAISE determine how long a prior authorization is valid. It depends on the level of care, it depends on the individual, it depends on the treatment plan, how long that initial prior authorization is valid. So you'll work with your RAISE to determine when the next authorization is required. It may or may not fall within that period. Will the RAISE require facilities to submit a CMN certificate of medical necessity? So the documentation of medical necessity will go through those prior authorization forms, and then the approval or denial process will occur based on the information submitted in the PAR form. If an outpatient agency is referring to inpatient, who initiates the PAR? I'd leave this question to the RAISE. My immediate thinking is that it would be the residential program, but some programs have the full continuum of services, and so if you're a provider that has outpatient and inpatient and IOP and what have you, then that may vary, but I'd leave it to the RAISE to determine. Oh, shoot, okay, here we go. Will each RAISE have a pre-approval process for the program itself? Each RAISE will have its own prior authorization process. They will have procedures and, arrangements with each that apply across the board to all of their programs. As you start to work with an individual RAISE on a regular basis, you all have a workflow, and you all can troubleshoot with the RAISE as needed, but the RAISE will have policies that apply across providers and procedures that apply to each provider as well. Can the RAISE delegate authorization responsibilities to a treatment provider? I'm not entirely clear on what's being asked there. It is on the treatment provider to submit the prior authorization request, and then there's the RAISE responsibility to respond to that request. If there is another question there, I would encourage the person asking that one to frame that question to the RAISE as they present later on this morning. Do the level of care and prior authorization requirements also apply for primary care providers that are referring to external SUD services? So a primary care provider would never need to submit a prior authorization request for residential treatment for an individual. That prior authorization request should come from the residential treatment provider. Is that continuum program free as long as we are registered with Medicaid to provide care? We will be talking in the stakeholder meetings about access to the software. So one of the things that we want to figure out is how do we appropriately determine how many user licenses each agency gets. So we'll be working with you all, having that conversation. That's really where the cost is. The training is going to be provided. We're developing plans to make sure that training is available as you have new staff come on and that sort of thing. So we're thinking long term and thinking about a sustainable plan for ensuring that training is available. The user licenses are the year-to-year cost for the program. That's also being covered with the budget that's been granted. We need to determine how many user licenses each provider gets. This is not an infinite amount of money, but what our intention is to ensure that each program gets sufficient licenses to cover the assessments that need to be done. So we'll talk about that further in the stakeholder workaround continuum, which is the name of the software. Yeah, great question. So can continuum be used for reassessment to step clients down as well? Yeah, and it's an abbreviated assessment. You don't have to repeat everything. That is historical data. You wouldn't need to ask them about their family history twice, right? So continuum is smart in the sense that when you go back into that client's case file and say I'm doing a reassessment, it will prompt you to complete information only in the fields that could have changed during their engagement in treatment, or even maybe they were on a wait list or something and you're checking in to ensure that they still have medical necessity for that level of care, or this person didn't engage in treatment after all. They didn't show up on the day that they were scheduled to admit to the facility, and then a month later, they've come back and they're more ready to engage in treatment. So you can update their information based on the information that exists in the software already. Now, the treatment plans, there's a question. I heard that the array will use the treatment plan in addition in determining medical necessity. So the treatment plan, of course, the expectations that a clinician would have about, how someone would progress through treatment based on their needs is something that's factored into level of care decision making in ASAM criteria. So to the extent that being true to some extent has an influence on the level of care recommended, but it's not as if the ASAM criteria is applied and a level of care, so ASAM criteria is applied and a clinician has to look at treatment planning as well. No, that's not the case, but in using the ASAM criteria, the clinician will do that assessment, assess the individual's needs, and then think about how their needs would be addressed in treatment, and that's part of the decision-making process. But ASAM walks through that and helps an individual determine what level of care is needed. Will the department be tracking any variance across the range in regard to prior authorizations, denials, et cetera, and trying to ensure consistency across the regions? Yes. In fact, we're in the process of building a monitoring plan so that once these services go live, we have a sense of exactly what's happening. So we're going to be tracking, how many prior authorizations are submitted, and, how often the array is agreeing with the initial recommendations. We're going to be looking at how many admissions are happening per region. We're going to be looking at average length of stay per region. So we'll be monitoring many things as the benefit goes live and over time as well, so that we can understand variations by provider, by region, and some of those trends. Okay. That's the last question in my queue right now. I'll take another minute just to see if any more come in. Okay, we are going to break there. Victoria, if you'll let people know when to come back, then we'll take a little break and then we'll come back to our next section of content.
Hi everyone, we are going to go ahead and break until 10:25, so please come back and join us at 10:25 and we will continue our training. Thank you so much.